So I'm going to present the case about cryptogenic organizing pneumonia. And this was a very atypical case that I came across during my externship. And this was about a 61-year-old African American female. She presented with typical features of fever, productive cough, malaise, and she was short of breath since 5 days, and she denied any chest pain, any palpitations, any pedal edema. Typically, you usually look for any CHF exacerbation for such cases who present to the emergency department with these, or you think more in terms of pneumonia. But she was also saturating at 88% on room air, and she was typically in distress. Her accessory muscles were prominent and she had intercostal retractions. And when we auscultated her, there was dullness, there was crackles that were heard at the base of the lung, and then there was also dullness to percussion on the left base. So we typically thought that this was a case of a lobar pneumonia, which was exacerbating the COPD because she gave the history of having COPD, and she was a smoker, and she was on other long-term medications for COPD as well. And we typically admitted her, gave her the usual treatment after initial evaluation, which was taking x-ray, chest x-ray, and performing blood gas and looking for any markers of sepsis or any other focus of infection. And during her initial evaluation period, we came across that she was having significant leukocytosis, and she had elevated PT, PTT, and D-dimer, which indicated towards sepsis and lactic acidosis as well. And she was saturating pretty bad when she came to the emergency department, but with 3 liters of oxygen support, she was still able to maintain good enough. But the lactic acidosis was significant, and also she was hyperventilating. So as usual COPD patient, you start on empiric antibiotic coverage, and then you shift to more specific antibiotics later on. So we did the same, giving her oxygen support, nebulization, giving her solumedrol, and then also starting her on the empiric antibiotic coverage with low molecular weight heparin, which was showing a significant reduction in the symptoms which she presented with initially. But the most catching feature about this case was on the repeat chest X-ray which was done, the presence of infiltrates and presence of prominent bronchovascular markings that surprised us. So what we did was, despite the initial antibiotic coverage and giving her oxygen support and whatever treatment which was given for COPD, that did not help, and she was significantly showing high inflammatory markers. For a period of 7 to 10 days, we thought of running some other tests like acid fast bacilli, looking for those, and going for serum angiotensin converting enzyme levels. And we also did a high resolution CT scan of her chest, and then we came up with findings that were pretty bizarre. And it showed that she had significant hilar lymph nodes enlarged with subcarinal masses, and then there were retroperitoneal lymph nodes extensively enlarged, portocaval lymph nodes enlarged, and also there were consolidations and opacities which were multifocal in distribution. So these findings in the CT were typically different from what we diagnosed the patient initially with. And there was a dilemma between the diagnosis of COPD exacerbation from pneumonia versus some underlying lymphangitic condition, or maybe a connective tissue disorder or a sarcoidosis. So we decided to run some angiotensin converting enzyme levels, and those returned back negative. To our surprise, what we did was, the next step for any person who was still hypoxic despite the intensive management given in the early phase was bronchoscopy. And to our surprise, the bronchoscopy did not reveal anything which was significant. As you can see, some images which I've put in from the bronchoscopy which was performed in her. But the X-ray and the repeat high-resolution CAT scan still showed the same findings. And so since we were so intrigued about what was exactly happening in this case, we decided to run in biopsy for this patient, and it was on this biopsy that it was diagnosed that there was a lot of multiple fibrotic waxy lesions that was in the gross specimen. And then in the microscopy, we found that there were a lot of fibroblastic plugs. And the diagnosis given by the histology and the pathology people was cryptogenic organizing pneumonia. So it was a diagnosis of exclusion for us because the initial findings were typically that of a COPD exacerbation. And then so we decided to take up this case and know more about what this type of organizing pneumonia is. It happens when there is injury to the wall of the alveolus and there is chronic inflammatory cascade that begins. And this results in a type of fibroproliferation, causing the typical pattern that was seen in the CAT scan that was run on this patient. And this type of injury usually is said to be reversible because as soon as the causative agent, in this case, since we say that this is idiopathic, we do not really understand that what triggered the inflammatory cascade. But sometimes there are certain questionable role of smoking or gastroesophageal reflux disease that could precipitate that. Or it's also very important that you rule out hypersensitivity reactions to coal dust, to silica, to asbestos, or any other occupational lung disease, which is pretty easy to confuse with this condition. And it is then that you go on and decide that this must be happening due to some underlying idiopathic pathology where the inflammation has triggered the leak of plasma protein into the alveoli, causing the damage to the alveolar membrane, impairing the diffusion capacity, and also causing a lot of fibroblastic activity and fibrosis. And the findings in the histopathology, typically for such cases who are presenting with idiopathic cryptogenic organizing pneumonias, they show the findings of Mason bodies. These are basically fibroblasts that stain very pale, and they are nothing but loose collagen, and they assume a polyp like shape, and that is identified most of the times by the pathologist who will inform you about this. Besides that, since this is an inflammatory condition, you also see a lot of lymphocytes and macrophages coming into that area. So these were the biopsy findings. This female who presented to us with the typical findings of a pneumonia that was not resolving despite the initial aggressive therapy and also giving steroids, showed a resolution when steroids were added for longer duration. So this was indicating that it is a steroid responsive thing, and this is an inflammation that was triggered due to an unknown etiology. So in summary, I would like to say that this was a case of COPD exacerbation that presented with a lot of other findings. That was sepsis, transaminitis, lactic acidosis, dyselectrolytemia. After extensive workup, conclusive biopsy coming up with findings of multifocal pattern of idiopathic organizing pneumonia that almost looked like sarcoidosis, to our surprise came up as idiopathic organizing pneumonia that was showing a very good response to long-term glucocorticoid therapy. It is also very important that you remember that ruling out COVID-19 infection and post-COVID fibrosis induced patterns in the CAT scans that are typically run on these patients. So in the end, I would like to just thank my mentor, Dr. Waqas Bernie, and California Research Institute for allowing me to present with a case that was overwhelming for us, yet it was something that was beneficial and helpful for all of us. And maybe this helps other people who have come across some cases of pneumonia that could typically present with these findings but may not resolve with initial therapy. And these must be kept in mind as a diagnosis of exclusion. Thank you.